Thank you.
Thank you very much, and I would like to thank Professor Cittadini for having invited us to present our work here today. Most of the things that we need to say regarding the use of fertility preservation techniques, they have already been said, and they have been said by the pioneers, the ones that developed the techniques, and they have been there from the very beginning. So I will just do a brief introduction, and I will go to the data of our study. Needless to say that nowadays, our colleagues oncologists, they are doing very well, and more the patients, they are surviving. So new problems arise, and the side effects of those treatments that they need to cure cancer need to be treated also, and one of them is infertility. Fertility preservation should be beyond discussion. That's something we all agree. Most of the societies, they include fertility preservation into the guidelines when treating cancer patients. And fertility preservation should be done in a holistic manner by oncologists, by gynecologists. Probably the main key step is information, so the patients should be informed about their options, and if possible, they should have access to that options. There are some established methods recognized by most of the societies, like embryo or oocyte vitrification, even though, as we heard today, some countries, they are moving forward, and they are also considering ovarian cortex transplantation as an established method. And there are also other methods. We also heard about them today, like the use of GnRH agonists to potentially preserve fertility, although they are still in investigation. So when it comes to oocyte vitrification, in fact, most of the data that we have nowadays, they are indirect data. They are data that comes from oocyte donation programs, from oocyte banking, or data that come from infertile patients not having any malignant condition, or even data from social freezers. Regarding ovarian cortex transplantation, we have been presenting data with more than 130 live births last year. So based on personal communications, I think I would not be wrong if I said that nowadays there are more than 150 live births, although publication bias exists, especially regarding the denominator. That's also an issue that has been raised today. We don't know exactly how many procedures have been done all over the world, and this is something we are trying to work in from the International Society for Fertility Preservation. We are trying to build a register to account for all the procedures done, not only the pregnancies, but also the attempts when we do ovarian cortex reimplantations. Basically, in our center, we have a management algorithm in which patients who had realistic survival chances, and this is a difficult question to answer, they are offered very often gonadal protection, even though it has not been proven that they can have an effect in terms of pregnancy rates. But we also use them for other means, for example, to avoid genital bleedings during thrombocytopenia that is caused for many of the chemotherapeutic agents. And we always assess the ovarian reserve of those patients. In our algorithms, if they have AMH less than 5 or antral follicles less than 6, we usually tell them to go for egg donation, not to delay the treatment. You have to take into account that this is done in a public context, so also resources have to be taken into account when taking decisions. If the ovarian reserve markers, they are okay, we always establish the time to treatment. If we have time, and by time I mean more than 15 days, we counsel the patients to go for oocyte vitrification or embryo vitrification. Is that their wish, although we try not to advise that option, because at least in my country, when you generate an embryo, the embryo is owned by the couple, so if the couple is split later on, the woman will have no right on that embryo, so she will not be able to use it. And if we do not have time, we always assess the risk of malignant cell contamination. We have been told that there are some diseases like, for example, leukemia, which are at higher risk. If the risk is too high to do any treatment, we usually, as it has been presented today, go for chemotherapy, and later on, if the condition and the chemotherapy applied will allow us to have still a residual ovarian reserve, we can do egg freezing or embryo freezing. If not, or if the risk is low, we go for ovarian cortex cryopreservation. We have also been using animal models, as you do in Israel, Dror, but we still keep that part of our program as an experimental part of it. And that's basically what we do with prepubertal girls. When we started our cohort, we started in a prospective way. So from the very beginning, we wanted to compare the efficacy of oocyte vitrification and ovarian cortex transplantation in these women undergoing gonadotoxic treatments. For us, the main outcome to compare them was in terms of live birth rates, which at the very end is what they want. The patients, they want to have kids, they don't want to have pregnancies, they don't want to have embryos, they want to have a baby at home. And that was our main outcome in our study. And we also wanted to analyze them by patient, because in many series that have been published, the results they are analyzed in terms of pregnancy, but not in terms of pregnancy per patient. So basically, all the patients that they were sent to us to undergo fertility preservation techniques, we selected those that they finally underwent the procedure, and we made two cohorts, one undergoing ovarian cortex cryopreservation and another one undergoing oocyte vitrification. Then we look at those patients that they came back to use their tissue or their oocytes, and the inclusion criteria in both groups were, as I told you at the beginning, reasonable prognosis, high risk of infertility. Those are the ones that they would benefit from fertility preservation techniques, and we only took into account the patients that they finally did it. We didn't include patients over 40 years old, although we did some procedures in those patients. That's basically because that's not covered by our social security system. We didn't include in this study prepubertal patients because they have not used their tissue. We have not reimplanted back any of the patients that they were prepubertal at the moment of ovarian cortex retrieval. We didn't include patients that they have undergone both techniques, because we also have patients that they underwent both oocyte vitrification and ovarian cortex transplantation, or those that they used embryos as a fertility preservation technique. We didn't include patients that they underwent ovarian cortex transplantation only for endocrine purposes. And of course, we didn't include patients that they didn't follow the procedures. The way our fertility preservation program is based is basically a public-funded program together with a private program in which everything is covered by a foundation, so the access is free for all the patients, regardless if they go to one of our clinics or they go to our NHS hospitals. It covers basically all Spain, and while we do the collections in all of our clinics, we have the ovarian cortex retrievals and reimplantations centralized in just one center in Valencia, at La Fe University Hospital. You have been shown how to do retrievals and reimplantations. It's a very easy procedure. In fact, if the risk of ovarian failure is very high, we take one ovary. If the patient, according to their conditions and the treatments they are going to receive, or if they are below 38 and they are not going to have a castrating treatment, we try to keep at least half the ovary to have a place in which we can reimplant the tissue back close to the medulla. And we do it by doing hemiophorectomies or just doing a retrieval of the cortex exclusively. And this is very easily done by laparoscopy unless there is a contraindication for general anesthesia. In such cases, we do a mini laparotomy, and the surgical procedure it does not change. Once the cortex is out, we try to take all the medulla out of that cortex to keep fragments measuring 1 millimeter in width. And this is the way they look like when we have taken the medulla out. We use a slow freeze protocol based on the MSO, and we keep our tissue in ethinyl vinyl acetate bags. For the patients that they undergo ovarian stimulation, we do not do random start. We almost do random start, but we try to avoid the late follicular phase to avoid the follicular dominance. And the protocols that we use, they are always short protocols with antagonists. And in cases with hormonal-dependent diseases, we always use letrozole as an aromatase inhibitor. As I told you, we also do stimulations in the luteal phase. In fact, they work very well. In our hands, we usually get more oocytes, although the maturity of those oocytes is slightly lower. So at the very end, the amount of M2 oocytes that we can vitrify is exactly the same as if we do it in the follicular phase. These are the numbers that they have been included in the study, more than 1,000 patients undergoing oocyte vitrification and 800 patients undergoing ovarian cortex transplantation, which in fact reflect 57% of the activity, of fertility preservation activity for medical reasons done in Spain, and more than 60% of the activity of ovarian cortex retrievals in Spain. Among all those patients that they came to us to do fertility preservation, only 49 used the oocytes afterwards, and 44 used the ovarian cortex, which is around a utilization rate of 8%. This is probably the reason why this type of programs should be publicly funded. Otherwise, they are very difficult to maintain. But those are the same utilization rates that we can see in other programs, for example, sperm freezing programs. When we compare the characteristics of the patients that they underwent the different procedures, they were quite similar, although the patients coming for oocyte vitrification, they were slightly older, although there were no differences in terms of ovarian reserve measured by AMH. The duration of the procedure, of course, it was different because that's part of the selection criteria. If you don't have time enough to do an ovarian stimulation, you send the patient for ovarian cortex retrieval. In general, from the moment that they do the first consultation to the moment in which they are sent back to their oncologist, it took 4 days and a half in average for the ovarian cortex transplantation, and 24 days for the oocyte vitrification patients. Of course, it can be done in shorter times, but the conditions, they are usually not so urgent. Just to give a picture of how fast can be done, for example, we have done ovarian cortex retrievals in non-Hodgkin lymphoma patients, in Burkitt lymphoma, in which the patients, they come to us in the morning, we do the ovarian cortex the same day, and they start chemotherapy in the afternoon in the intensive care unit. Regarding the different pathologies that they have been done, the most prevalent pathology in our series is the breast cancer, followed by lymphomas. We have also done other conditions, gynecological malignancies, sarcomas, mainly in pediatric populations, or post-pubertal pediatric populations, because the prepubertal, we didn't include them in this study, but also autoimmune diseases, which are not malignant diseases, in fact. Regarding the parameters of the ovarian stimulation in patients that they underwent oocyte vitrification, as you can see here, and this data, they have been published previously in another series only with our patients undergoing oocyte vitrification. the mean number of vitrified M2 oocytes is 8.1. The only problem is in those patients, usually we cannot repeat a second cycle because we usually don't have time to do it. Sometimes we can, but most of the time we cannot. And I will also highlight the very few number of cycles that they have been canceled because of various reasons. When we look at the patients that they come back to use those oocytes or to use the ovarian tissue, in fact, they were slightly different in terms of the status post-chemotherapy. So the rate of amenorrhea longer than 1 year was higher in the group of ovarian cortex transplantation, so a priori one could think that they were worse prognosis patients. The age at retrieval was similar, the age at utilization was also similar, and the storage time varied in between 3.9 years in average for the oocyte vitrification patients and 5.5 for the oocyte, for the ovarian cortex patients. Regarding the pathologies, again, breast cancer is the most prevalent pathology in our population. And in terms of pregnancies and live births, although we couldn't find any significant difference, you could see that there are some trends always higher in the arm of oocyte vitrification, 42.9% in the oocyte vitrification versus 34% in the ovarian cortex transplantation, and in terms of live births, 34.7 versus 22.7, and we will talk about this later. When we do the analysis per patient, not per pregnancy, the pregnancy rates, they were quite similar because only a few patients, they had multiple pregnancies and live births. So the results is 32.6 in terms of live births for the oocyte vitrification group and 18.2% in the ovarian cortex transplantation group. And these rates, if we compare them, for example, to our social egg freezing program, especially in the oocyte vitrification group, which could be techniques that they are exactly the same, the pregnancy rates, they are slightly lower. So this brings the question if these techniques and these results that we have in social freezers, in infertile patients, they are really extrapolable to the oncologic populations. When we analyze the results per disease, we couldn't find any differences in terms of the characteristics of the patients or the results, but you have to take into account that the numbers, because of the nesting analysis, becomes very low, which happens with almost all the series of fertility preservation. We had lower rates as compared to other groups, lower pregnancy rates and live birth rates when we compare our series to that of Belgium or Israel. And we wonder why. I mean, we were using the same surgical technique you are using in Israel. We basically implant the cortex in between the medulla and the remaining cortex of the patients when we can. Otherwise, we create peritoneal windows. We use pretty similar freezing protocols for the cortex. And basically what we realized is that we couldn't get any ongoing pregnancy or, well, any live birth, in fact, in patients aged more than 36 at the moment of the ovarian cortex retrieval. Nowadays, that's why we do not offer this technique in patients over the age of 35, or if we do it, we really take into account the ovarian reserve markers, which at the beginning, in 2005, 2006, that's when we started to retrieve tissue, was not done because it was not available in our center. by doing that, we will probably improve our results. So I don't know to what extent it could be a good idea to open the criteria, especially in terms of age, unless we measure the ovarian reserve together to take it into account as a parameter of potential results. When we look at the parameters of the different techniques, we have oocyte survival rates that they were close to 80%, but they are also far behind what we have previously published in our hands in social freezers or egg donors, in which we can find survival rates after thawing of the oocytes close to 90%. Those patients, in general, when we generated embryos, they had surplus embryos that they could be frozen. And in fact, some of the patients in our series, they have undergone more than one embryo transfer. In fact, we did 68 of them. The embryo survival rate is very good on day 5. We now only transfer embryos on day 5. And here you can also see the clinical pregnancy rate per cycle and per transfer, being close to 36 and 27% respectively. The live birth rate per transfer was 30%. And again, the same figures that you have already seen regarding the number of pregnant patients and patients with live birth, which were 40% and 32% respectively. Regarding the ovarian cortex transplantation, we did laparoscopy. This is for the reimplantation process. We did laparoscopy in one patient, laparotomy in, well, in fact, this is not correct because we did laparoscopy in 3 patients. There's a typographic mistake, and laparotomy in 41 patients. Nowadays, we do more procedures by laparoscopy. At the very beginning, we decided to do that by mini laparotomy because that was the way we were taught how to do it, and we didn't want to change it because we were having good results. In some cases, we had to put tissue in subperitoneal pouches because there were no ovaries remaining, or because the amount of tissue that we had in our EVA bags was too high, so the remaining cortex was not enough. We didn't have enough room in the remaining cortex to put all the tissue back. We usually replace half the tissue that we harvest, so basically around in between 2 and 3 square centimeters. The recovery of the ovarian function after grafting is close to 100%, but you have to take into account that, as we have also said during the previous talks, endocrine recovery is not exactly the same as fertility. So the clinical pregnancy rates and the live birth rates after ovarian grafting, it was 11% spontaneously, 11% after IVF, so more or less half and half of the patients, they had babies using either way of getting pregnant. Which in fact, I mean, this is additional, so close to the final live birth rate was close to 20%. Just to conclude, I would like to say that by doing this study, probably the most important thing is that we have useful information in terms of numbers to counsel our patients and our oncologists, our colleagues oncologists, in terms of providing information about the potential results that one could expect. And as I have previously said, we should take into account the population in which we are doing this study. We were taking patients up to the age of 40, regardless of the ovarian reserve at the very beginning of the program. Later on, we established our criteria to set at cutoff points, not to include patients with low ovarian reserve, but that can have, because that can have a detrimental effect on the results. even though we are far from pregnancy rates of 100%, we all know that 100% does not exist in medicine. Both methods, they are effective, and they are effective to preserve fertility. And in fact, some of them, like the ovarian cortex transplantation, are the only method in some scenarios. For example, the prepubertal girls or the girls that they don't have time enough to do an ovarian stimulation because of their underlying condition. There is a trend to higher clinical pregnancy rates and live birth rates in the oocyte vitrification group. We still continue doing our procedures. We still continue using those oocytes. We still continue using that tissue. So, of course, we will reanalyze our data, and we will see that trend becomes a real statistically significant difference in the future. And I will also highlight another important fact, and that's the fact that ovarian cortex transplantation, despite this lower trend in infertility results, it allows for natural pregnancy. And it also allows and restores ovarian function in terms of hormonal production. And this is something that some patients will take into account when taking decisions. For us, we do not counsel our patients to undergo OCT only for endocrine purposes any longer, and this is also because of the cost effectiveness. But in different scenarios or in different countries, that could vary. And that's basically everything I would like to share with you today. If you are more interested in having access to the details, this study has been recently published in March in Fertility and Sterility. And I would like to finish by thanking all my colleagues, especially my mentor in Spain, Antonio Pellicer, who started the program in 2005, and Javier Domingo, who is the person responsible to get all the data from the IBI group in the different clinics regarding the fertility preservation patients. Thank you very much.